person to person if it gets out of hand, but some people will be interested to hear the answer. So the first question I have here is from the MSF Asia Logco. It says, for regular IDP, the amount of inpatient department, IPD, the regular amount of litres per person per day is 40 to 60 litres. And you find it too much to exaggerate the figure 150 litres for Crohn environment, as procedures are not much different than a normal setup. In a word, fairly correct. If you look at cholera centre, we go from 80 to 100. And there has been a little bit of research done where we've had people sitting around in camps and actually calculating how much water people use, including caretakers, including other things that come. And so we've decided to push it up a little bit. 150, we say, is the minimum standards required. I know in emergency it will be very difficult to attain that, but it's a target to aim for. If you drop me an email, I can answer and be more specific just for you. Okay, I hope that answers a little bit of that question. And the next one that I have. The next one I have is another Watsan one.
Yeah.
Question on the waste area, laundry. As I understand, we can use the laundry and waste management of our existing facilities. However, we should receive specific protocols to manage the movement of laundry and waste from COVID area to a regular medical facility. Is this still coming? Yes.
It is. Look, already.
It's already. There's a couple of things on this, just to tell you that yes, you can use the existing laundry and the existing waste management area for your coronavirus centre, depending on how big it is and how much capacity you have in both the laundry and the waste management area. As I mentioned before, you'd be generating a lot of PPE, a lot of soft waste to burn, and if you only have like one intermediate burner, then maybe you might need to think about having a separate burning place for the PPE. And for the laundry also, if you have one little washing machine, you're creating a lot more laundry in a coronavirus than you do in a normal centre, so you might have to up it, but you can use it. And Anna, do you want to update a little bit on the documentation for the...
Yes, well, in fact, we have in the COVID, in the OCBA COVID hub, if you go to the IPC, you will see that in guidelines we have the SOPs for laundry, for example, so explaining very well how the circuits and how the procedure has to be done in terms of what PPE I need to use in which area and how do I have to transport. Then the protocol for the laundry, for example, is the same. There are no changes. So the SOPs are there. In case there is anything that you cannot find, let us know, because it's the documentation, it's already included.
And you can mention the video as well, the videos.
Oh, the videos. There are also videos that are coming to explain in a more visual way how these circuits and how these PPEs should be used. So they are going to be shared very soon, and we will. So it will be like another learning solution that we hope it will be helpful for you. Okay.
And where would they find the videos?
Well, the videos, if I am not wrong, are going to be uploaded first in the log. You can correct me this it's not going to be at the beginning in the IPC Watsan, but more in the logistic side of the SharePoint. But yes, we can confirm this, okay. Or maybe we can place them in both sides, so it's easier for everybody.
I think both sides would be good.
Yeah.
Okay, thank you.
And normally, we do regular updates by mail of what we are uploading. Okay, now this is a question from Liliana. Does the circuit has any difference if we talk about high or low active transmission? Okay, the principles of the circuit, no, it doesn't. What it could change, for example, the screening, you will need it, but maybe if you are in a place where the local transmission is not very high, maybe the number of cases with respiratory symptoms are not going to be high. Well, depending on the season of the year where you are. But so maybe you don't need a specific dedicated triage area, because you can have with an only one area, triage area, you can have enough separation among the patients, so you don't need this kind of double triage areas you need more staff, more space. But the principles will be the same. Once a patient arrives with a respiratory symptom in the screening, they should be provided by a medical mask. So if in case they cough and sneeze, they are not sharing the respiratory droplets in the waiting area. So this could be the difference, because the rest, if you have a suspected case that needs to hospitalization or something, there should be also, he or she should be admitted in the isolation area. I hope I answered your question.
Yeah, it's quite good. And remember, Anna, they've actually left their names there, so we can go back to them afterwards and say, did we answer your question correctly, and would you like any further information? If they're not happy with the answer, they're more than happy to contact us, and we will give more information. The next one is, could you share any examples from other missions on circuits and layouts? MSF Juba Loco. Yes, certainly we can, but I don't think we'll be able to do it now. I will send you some other ideas on how to do circuits and things, and you can ask me more detailed questions. And I will also talk through Pau Cabrera, the construction referent, who's also helping doing the circuits with Manuel. And
we're listening now, so he knows we are going to ask him about this.
And Manuel and Anna, who does circuits as well. Okay, so yes, thank you for that, Juba. I can't supply any now, but we'll try and send some through to you. Okay, next one I think is yours, Anna.
Sorry, for the evaluation of patients not COVID in the context of community transmission, the current indications for the use of PPE for evaluation of patients, how we handle with the limitation of PPE. Well, yes, as I said, we are aware that there is you are facing a shortage in terms of PPE. And this I have been also discussing with different medcos and TESACOs already. So for me, in a context of local transmission, what everybody should wear in the healthcare facility would be the medical the mask. Okay, so please try to have enough mask for all the staff in the healthcare facility, and then prioritize the PPE, the rest of the elements of the PPE, the gown, for those staff that are working in the areas with confirmed or suspected patients, okay? Because you can have some areas where you are not working with suspected or confirmed patients, though we know that we have like a window of 48 hours that maybe I'm not having symptoms, but I can be infective. So you will need to prioritize. Okay, I would try to give masks to everybody, and then the rest of the PPE I would prioritize for the staff working in the COVID areas. And I think if you need to have further information or discussion, we can do it. Either in another meeting, because otherwise it's it's a very long discussion, and we know maybe it deserves a session by itself. Okay.
Okay, very good. There's another PPE one. I think, and we could mention that if people want to have more detailed information about PPE, I think it's a subject that comes. This was supposed to be just a general overview for you of is your hospital or is your health structure ready for coronavirus. We're very happy to go into these questions while we have time, but I think if you really have lots of requests on PPE, then maybe we can find another way of giving everyone information on that. Anna, what do you think? Or we can ask this question on Mexico first if you want, but there could be another forum for PPE later if needed.
Yes. Okay. Yes. I mean, from my side, I think it's one of the trending topics. But what we didn't want to start today is with a PPE discussion, because we also want to show that there are also many other things that you need to consider a part of the PPE. So I think that maybe the PPE deserves a specific session, but you need to consider first the whole picture, because the PPE by itself is not working. It's necessary, but it's not enough. So happy to have another session about this. No worries.
So you have another PPE question, sorry.
Yeah. I'm not surprised, to be honest.
In Mexico, we face a challenge with the PPE that the MOH staff is using. The fear is the virus has made the PPE use exaggerated, which is exactly what Anna said. The improper use of PPE causes the problem. They refuse to work and enter the area of COVID if they don't have double gown, over double gloves, no gloves, change between patients, double shoe covers, double eye protection, double masks, and medical masks. Of course, some of these measures are supported from the MOH responsible. Oy. Do you have suggestions on how to approach this challenge, or at least mitigate the impact for the doffing procedure, for example, and also the supply? You've missed out the supply and the short of those materials.
Yeah. Well, yeah, unfortunately, there are many, I think we are facing many situations like this one in our field. I think what is important, the message that is important to pass is that the more complex the doffing procedure is, the higher risk of cross-contamination during the doffing procedure, okay? So not because we are using more PPE means that is more correct. We need to use the PPE that is required for each type of infectious disease. So, for example, in Ebola, the PPE and the doffing procedure is more complex, but because the way of transmission of Ebola is different, so it has these nuances and is justify the complexity, but not in COVID. So for me, this would be the message, no? That is going to complicate more, and it's going to be more risky for the staff. Even if you try to negotiate this, you are not managing to reduce this or to mitigate this. What I would say is, like, for this, you need to train very well your staff on this complex doffing procedure. So if you know that they will need to work with double glove, with double, I mean, they will need to be trained and to know very good the different steps for doffing all these elements. So, but first I would really try to convince them, though I know it's not easy, about this. And also because at the end, as Paul was saying, maybe we are wasting PPE, and I don't think we are in a situation where we should be wasting PPE. We need to use the PPE that is required and how it is required. But anyway.
Okay. No, fine, Anna. And I think this has brought up the question that there's going to be a lot more questions on PPE as it goes along. There is some interesting documents, as we said, in the links we sent you that will have some information on PPE, the right ones to use and stuff, but how to convince your staff to relax their paranoia is going to be a difficult challenge.
Well, I think also when the staff is trained and they are trained about how the transmission is done, what are the precautions that we need to put in place, that the basics already are giving a very good protection, how we need to move within the hospital. This is increasing the confidence of our staff when we are sharing clear information, understanding their challenges. I think these are key elements that are required also for the preparation. And if some adaptation needs to be done, they need to be very well explained, and why, and the staff needs to be involved, because otherwise people are not going to understand these changes and they can lose the confidence on the managers, which it's not helpful at all during an outbreak. So I think this is also tips that we should also keep in mind that maybe we didn't say in the presentation. Okay.
Very good. Liliana, what about the cohort wards for suspected in areas where the confirmation by test is not going to be possible or is going to take a long time? How to assure the reduction of cross-infections from positive not known to the real negative people?
This is a
good question, Liliana.
Good question showing the field reality. So thank you, Liliana. Well, as we said, ideally, mainly suspected cases should be placed in a single isolation room, but we know this is not possible in many places. So if we need to keep the suspected cases in a cohort ward, what we need to do for mitigate this risk of cross-infection among the patients is to increase the bed distance. Normally, what the bed distance for example, in the confirmed area would be like 1.5 meters, but in suspected case ward, we recommend, to keep at least 3 meters among each bed in order to reduce the risk of cross-infection among the patients. And also it's very important to try, for example, to reduce, if it's possible not to do aerosol generating procedures in this cohort ward, better, because this airborne transmission is going to be risky for these suspected cases that we don't know who is positive and who is negative. So unless it's vital, I would suggest don't do aerosol generating procedures in this cohort ward, and increase the distance between the beds. Is 3 meters.
There's also a slight Watsan solution you can do is limit the number of areas that they share. For example, if they're only sharing one latrine, maybe you want to bring in a system of bedpans or something like that, so that you're not having shared areas where it's possible to spread contamination. Sorry, Anna, I just want to put that at the end.
No, perfect. Thank you for this. Okay.
Okay, are we going to share this presentation in SharePoint?
That's a very easy question. Yes. Yes, Paco is, well, I would like to say that thanks to Paco and Cristina, who are helping us with all the logistic things, organization of the webinar. So Paco is recording this, and it will be uploaded, if I am not wrong, in the COVID hub. So everybody can go through either the webinar or I think also the presentation. Okay. Okay.
Currently addressing the way to return to regular activities, mobile clinics, in a context of community transmission of coronavirus. What would be recommended regarding this? General IPC reinforcement or adding specific recommendation measures for community transmission of coronavirus?
Well, yeah. I think the thing is that this question is not really focused on the, because you are talking here about mobile clinics, which is more in the community. And here we are all more talking about the healthcare facility. Anyway, what I would say in a context of local active transmission, you will come to a new normality, as we are also saying here in Spain. So I would say in a general way, continue doing your standards, with focus on cleaning, disinfection, hand hygiene, and then respiratory hygiene. So I would say try to ensure physical distance even when you do the mobile clinics. And if you cannot ensure the physical distance, probably all the staff will wear a mask for the medical activities, because the risk, it's in a local active transmission. Yeah, I think this would be the most important thing. But really, for this type of activities, the basics are already the foundations. So focus on hand hygiene, respiratory hygiene. Try to keep the distance as much as possible. And then,
if you need further information, we can contact, or Anna, you contact Anna directly, and she'll put you in touch with someone that might be able to give you some more help on community IPC.
Yeah.
Okay.
Okay.
Thank you. Very good.
We can have a last. It's not a question, but a suggestion from Matthias, who is the new IPC. So thanks a lot, because he's saying if we could remind people which are the aerosol generating procedures that we were talking. So yes, as we were saying, these are medical procedures, and we are saying, for example, when you have to intubate a patient, when you have to do CPR to a patient, that's an aerosol generating procedure. But for example, where you are providing oxygen to a patient with a normal oxygen device, an oxygen cannula, an oxygen mask, that is not an aerosol generating procedure, no matter the flow of oxygen you are giving to the patient. Okay, what is an aerosol generating procedure? It's using another device that is high flow oxygen, but this is mainly for ICU. And nebulizations, we consider that have a risk of aerosol generating procedure, and we are recommending that instead of nebulizing, if you can just give the medication with a chamber, so you don't do an aerosol generating procedure, this is what this is a good point. But these are in general the most common, thinking in the field, aerosol generating procedures. But there will be, like in the next days, also a very clear document about what it is an aerosol generating procedure.
So that's a very good point by Anna. If there's documents coming out on what APGs are, and also if you have any specific questions on that, I think that's quite a specific question to go into. But okay, very good.
So
any last points from anybody? Anna, any last points? Let's wrap this up. Oh, 4 o'clock on the dot. Look at that.
Yeah, it's already gone.
Look at that. That was so quick. It's interesting questions. I enjoyed the questions from everybody, and we had up to 31 participants, I think. So I think we can say that was quite an interesting, successful little presentation. Please feel free to write anything more in this conversation box if you want, or to contact us separately or in any way, especially if you have any more suggestions you want from other webinars in the same kind of format, where it's the information is very quick. We only did 25 minutes, I think it was, on presentation, or 30 minutes on presentation, and the rest was for you to generate the questions. So thank you very much for the questions, and we're looking forward to more questions and more suggestions from you in the future, please. Anna?
No, thank you so much, and thank you for your questions. And yeah, don't hesitate to give us your input so we can continue programming more sessions.
And the last thank you is to Paco and Christina. Christina helping do all the presentation and stuff, and Paco doing all the technological hard stuff. So without it, we could not do it. I feel like doing an opera speech, you know, at the end of the Oscars. And I'd like to thank thank you.
Thank you, guys. Awesome.
Thank you, everybody. Thank you very much.
Thank you. Bye.